Hi, my name is Aubriana Holzworth, and today I will be discussing the use of inhaled loxapine for the treatment of acute agitation. The learning objectives for this presentation are to list the current therapeutic options for treating acute agitation, to explain the benefits of using inhaled loxapine to treat acute agitation, and to identify the type of patients that would be appropriate candidates for inhaled loxapine therapy. I'd like to start off by giving a little bit of background information on acute agitation. It is estimated that 1.7 million individuals present to the emergency department during episodes of acute agitation. In 2011, a survey of emergency room physicians and residents found that 78% reported experiencing some form of workplace violence within the past year. So from these two facts, we can see that acute agitation is a very prevalent issue and one that we should all be aware of as pharmacists, especially if we are going on to work in the emergency setting. So acute agitation itself is not a disease state, but it's rather a symptom of a variety of medical or psychiatric conditions. The mechanism behind why acute agitation occurs is unknown, but it's likely due to the dysregulation of dopamine, serotonin, or GABA, all of which are neurotransmitters in the brain. In the realm of psychiatry, acute agitation can be defined as excessive verbal and/or motor behavior, and that behavior can be described as loud, disruptive, hostile, threatening, or combative. Patients that exhibit this type of behavior have the risk of evolving quickly into aggressive behavior, and when a patient is aggressive, they are at an increased risk of harming themselves as well as the healthcare providers that are caring for the patient. Another risk that may come up is that a patient exhibiting this type of behavior is more likely to be admitted for inpatient hospitalization, which is also something that we want to avoid. So due to the risk of harm to the patient or healthcare providers, as well as the risk of inpatient hospitalization, acute agitation should be considered and treated as a psychiatric emergency. There are 6 goals for treating psychiatric emergencies. The first is to exclude medical causes of symptoms. The second is to rapidly stabilize the acute crisis. The third is to avoid coercion. The fourth is to treat in the least restrictive setting. The fifth is to form a therapeutic alliance. And the sixth is to ensure appropriate disposition and aftercare plans. I would particularly like to draw your attention to numbers 4 and 5. So number 4 is to treat in the least restrictive setting, and this applies to patients with acute agitation because if those patients are not managed appropriately from the start, it could progress to a point where patients have to be physically restrained. So this can be an extremely uncomfortable situation for patients, and it can in turn affect number 5, which is the therapeutic alliance. Essentially, the therapeutic alliance is the relationship between patient and healthcare provider or the healthcare staff that is treating that patient. And when a patient is treated against their will, whether it be through physical restraints or medication that they're unwilling to receive, that can cause the patient to lose trust in their healthcare provider, and that therapeutic alliance will not be as strong. This could ultimately affect the outcome of the patient's treatment and make it more likely to be unsuccessful. So we want to avoid negatively affecting the therapeutic alliance, and we also want to avoid treating the patient in a way that makes them feel restricted. So next I would like to introduce some scales that are used to assess acute agitation. We will see these scales used later on throughout the clinical trials that I will discuss. So the first is the Positive and Negative Syndrome Scale, abbreviated PANSS, and you'll also see my abbreviations throughout the rest of my slides. The PANSS is a scale that contains 30 items, and it was developed specifically for schizophrenia, but it does cover a broad range of symptoms relating to psychosis. There are three categories in the PANSS: the positive, negative, and cognitive components, and each individual item is rated from 1, meaning absent, to 7, meaning extreme. The PANSS can be shortened into an abbreviated version called the excited component, abbreviated EC, and this excited component has 5 items that are specific to acute agitation. The next scale is the Clinical Global Impression, or CGI scale, and this scale talks about the severity of illness as well as the global improvement from baseline. I will discuss what each of these means in more detail in just a few slides. Here's a visual depiction of the entire PANSS, so we can see the symptoms separated into each of their categories: the positive, negative, and cognitive symptoms. And highlighted in red are the 5 items that are in the excited component scale. These 5 items include excitement, hostility, tension, uncooperativeness, and poor impulse control. And as I mentioned, these 5 items are specific to acute agitation. So since the PANSS-EC is only these 5 items, it can be a quick and easy tool for a clinician to use to assess how a patient is presenting in their agitated state. For the Clinical Global Impression Scale, we have number 1, which is the severity of illness. This question is asking the provider how severe the patient's illness is at that moment in time. So the provider is able to give the patient a 1-number numeric value that assesses the severity of their illness. And that is from a range of 1, meaning the patient is normal and not ill, to 7, which means the patient is among the most ill that they can be. Number 2 is the Global Improvement Scale, which asks the clinician how much the patient has improved from baseline to after they have received treatment. So again, the provider gives the patient a 1-number score that indicates how much they have improved after receiving a treatment. So now that we know a little bit about acute agitation and how it is assessed, I would like to talk about the treatment options for acute agitation. There's 3 main drug classes that are used for acute agitation. The first is first-generation antipsychotics, abbreviated FGA. The next is second-generation antipsychotics, abbreviated SGA. And the last is benzodiazepines, abbreviated BZD. For the antipsychotics, as I mentioned, they're separated into the first and second generation classes. So for the first generation antipsychotics, the primary agent used here is haloperidol. There's many other medications in the first generation antipsychotic class, as well as within the other 2 classes, but I'm primarily highlighting the agents that we are going to see used for acute agitation. The route of administration is oral or intramuscular, and haloperidol, like many of the other agents that we are going to discuss, is available through other routes as well, such as intravenous, but these are not preferred routes of administration for patients with acute agitation. The mechanism of first-generation antipsychotics is likely due to the inhibition of dopamine, and the adverse events that we may see from first-generation antipsychotics are QT prolongation and extrapyramidal symptoms. For second-generation antipsychotics, the agents used here are primarily ziprasidone, olanzapine, and aripiprazole. The route of administration is also oral or intramuscular, and the mechanism of action is due to the inhibition of dopamine and serotonin. The adverse events that we may see with second-generation antipsychotics are the same as first-generation antipsychotics, being QT prolongation and extrapyramidal symptoms. However, with second-generation antipsychotics, there's less of a risk of these adverse events occurring than there is with first-generation antipsychotics. The next class is the benzodiazepines, and the primary agents seen here are lorazepam, midazolam, or diazepam. Their route of administration is also oral or intramuscular. And the mechanism here is that benzodiazepines act on GABA receptors. GABA is the primary inhibitory neurotransmitter, and it can counteract the effects of dopamine and serotonin. So as we've seen with the antipsychotics, they themselves inhibit dopamine and serotonin, and benzodiazepines act on GABA, a neurotransmitter that also inhibits dopamine and serotonin. The adverse events that we may see with benzodiazepines are sedation, hypotension, and respiratory depression. And it is important to note that in patients with acute agitation due to a psychiatric disorder, benzodiazepines should not be considered first-line agents because they do not treat the underlying cause of the psychiatric disorder. Benzodiazepines can be used as adjunct agents to help control the presentation of acute agitation, but the antipsychotics are the agents that we want to focus on because they will help treat the underlying cause. This leads us to inhaled loxapine. Inhaled loxapine is also known as brand name Adasuve, and it is a first-generation antipsychotic that was first FDA approved. The Food and Drug Administration approved it in 1975 as an oral agent to treat schizophrenia. It was not until 2012 that inhaled loxapine was approved as an inhalation to treat acute agitation. And there are other dosage forms of inhaled loxapine that are manufactured. However, the capsule and aerosol powder dosage forms are the only dosage forms available in the United States. The mechanism of inhaled loxapine is that it blocks dopamine and serotonin receptors in the brain, and the inhalation is rapidly absorbed with an onset of action of about 2 minutes. It is 91% bioavailable, and its half-life is approximately 6 to 8 hours. The inhaled loxapine device is pictured below. It's a breath-activated aerosol powder dosed at 10 milligrams once daily, with a maximum of 10 milligrams in 24 hours. It's very easy to use, and so if you take a look at the device pictured on the right side of the screen, on the left end of that device there would be a pull tab, and once that tab was pulled, the green light in the center of the device would light up, indicating the device is ready for use. The patient would inhale, not requiring any special hand-breath coordination, and the drug would vaporize during the inhalation and then condense in the patient's airstream. Because the drug is vaporizing, this device does use heat to help it do so, so the inhaler may feel a little warm to the touch during use, but it will quickly cool down. And as I mentioned, one very key point of the inhaled loxapine device is that it does not require special hand-breath coordination or any specific technique to use this inhaler. So it's very easy to use. The patient just needs to simply inhale. Another factor that goes into the use of inhaled loxapine is a risk evaluation and mitigation strategy program, also known as a REMS program. The purpose of the REMS program is to increase awareness of a potential side effect of inhaled loxapine, which is bronchospasm. Bronchospasm has the potential to lead to respiratory distress and respiratory arrest, so it should be taken seriously. And because of this, only facilities that are enrolled in the Adasuve REMS program are able to prescribe and administer the medication. And the medication also can only be used in the inpatient setting. It is not to be prescribed for outpatient use. There is specific monitoring guidelines that go along with the use of inhaled loxapine. So once a patient receives inhaled loxapine, they must be monitored every 15 minutes for at least 1 hour following treatment for signs and symptoms of bronchospasm. On page 10 of the handout, there is the protocol template for the monitoring guidelines provided by the REMS program for inhaled loxapine. So we can see all of the detail that goes into monitoring a patient after they receive this therapy. The facility also has to meet the requirements of being able to provide advanced airway management, such as intubation if necessary, and they must also have access to a medication that is a short-acting beta-agonist bronchodilator, such as albuterol. So now that we've taken a look at all of these medications, I want to go over the guideline recommendations for treatment of patients with acute agitation. It is recommended that first-line agents are oral second-generation antipsychotics, followed by oral first-generation antipsychotics, and then parenteral second-generation antipsychotics, followed by parenteral first-generation antipsychotics. The question that we would like to answer today is, where does inhaled loxapine fit into these guideline recommendations? In order to answer that question, I would like to look at several clinical trials to give us some more information on inhaled loxapine. The first trial is titled The Efficacy and Safety of Loxapine for Inhalation in the Treatment of Agitated Patients with Schizophrenia. This was a randomized, double-blind, placebo-controlled trial that assessed the safety and efficacy of inhaled loxapine versus placebo in agitated patients with schizophrenia or schizoaffective disorder. Schizoaffective disorder presents very similarly to schizophrenia, but has more of a mood component. But for the purposes of this trial, they are managed the same way when it comes to acute agitation. The study investigators looked at the change in the PANSS-EC score from baseline to 2 hours after a dose of study medication was given. And what they found was the decrease in the PANSS-EC score from baseline to 2 hours after the dose was significant in favor of the 10 mg inhaled loxapine therapy. The next trial is titled The Rapid Acute Treatment of Agitation in Patients with Bipolar I Disorder, and this was a multi-center, randomized, placebo-controlled trial that looked at the safety and efficacy of inhaled loxapine versus placebo in acutely agitated patients with bipolar I disorder. The study investigators looked at the same outcome as the previous trial, which was the change in the PANSS-EC score from baseline to 2 hours post-dose of inhaled loxapine. And the result that they found was that the decrease in the PANSS-EC score from baseline to 2 hours was significant for both the 5 mg and 10 mg doses of inhaled loxapine. So while both of these trials concluded that inhaled loxapine was superior to placebo in patients who are agitated with schizophrenia or bipolar disorder, the primary limitation to these studies were that they were conducted in a laboratory setting, patients gave informed consent, and it wasn't necessarily an environment that we can apply to a real-world setting. So this leads us into the primary trial called the PLACID study, which was a randomized trial comparing the efficacy and safety of inhaled loxapine versus intramuscular aripiprazole in acutely agitated patients with schizophrenia or bipolar disorder. The objective of this study was to evaluate the time to response after administration of inhaled loxapine or intramuscular aripiprazole in acutely agitated patients with schizophrenia or bipolar disorder. The study was designed as a Phase 3b, open-label, assessor-blind, randomized, active-controlled, prospective, parallel group, multi-center clinical trial, and it was conducted at 23 different centers across Europe. Patients were included if they were otherwise healthy but were considered to be clinically agitated, which was defined as a score of 4 or higher on the Clinical Global Impression Severity Scale. A score of 4 indicates that the patient is moderately ill, so all patients included were moderately ill or higher. And patients were excluded if they had agitation from other causes, such as drug or alcohol withdrawal, if they had active airway disease or any ongoing respiratory symptoms, if they were treated with benzodiazepines, hypnotics, or other antipsychotics within 1 hour prior to receiving the study medication, and patients were also excluded if they had a suicide risk or any significant organ dysfunction of any organ system, such as the kidney, liver, or heart. The primary outcome that the study investigators looked for was the time to response, which they defined as a CGI improvement score of 1 or 2 during the first 2 hours after the dose of the study drug was given. On the CGI improvement scale, a score of 1 indicates a very much improved, and a score of 2 indicates much improved. The secondary outcomes that the investigators looked at was the response at a various number of time points up to 120 minutes after dose 1, the number of patients who received 1 or 2 doses of study medication with or without the administration of a rescue medication, and it was not identified what the rescue medication was or what patients would be given the rescue medication. And they also looked at patient satisfaction with treatment. Overall, a total of 359 patients were randomized into the study over a 2-year period, and the baseline characteristics between both groups were relatively similar. So we can see in the table here that the average age was around 40 years old in both groups. The average CGI-S score at baseline was approximately 4.3 to 4.4. There was about an equal number of males and females in both groups, with the inhaled loxapine group having a slightly higher amount of males. And the clinical diagnosis was about 83% schizophrenia in both groups and about 17% bipolar disorder in both groups. For the primary outcome, the study investigators found that the time to response was 50 minutes for inhaled loxapine and 60 minutes for IM aripiprazole, which was significant in favor of inhaled loxapine. So of the patients with schizophrenia, there was 297 between both groups. It was also found that the CGI-I response was shorter in favor of inhaled loxapine than with IM aripiprazole in that subclass of patients as well. And the same result was also found in patients with bipolar disorder, with those who received inhaled loxapine having a shorter time to response than those receiving IM aripiprazole. However, in the subclass of patients with bipolar disorder, this result was non-significant, and this is likely due to the much smaller sample size of patients who had bipolar disorder. As for the secondary outcomes, the investigators found that there were significantly more responders in every time point in the inhaled loxapine group up to 60 minutes after the dose was given. They also found that 6.7% of inhaled loxapine patients and 9.6% of IM aripiprazole patients required a second dose of study medication. However, this result was non-significant. And I would also like to note that there was one patient in the inhaled loxapine group that did receive the rescue medication. There were no patients in the IM aripiprazole group that received the rescue medication. And again, there was no indication for why the rescue medication was given or what the medication was. Lastly, the investigators found that more patients in the inhaled loxapine group reported feeling very satisfied or extremely satisfied with their treatment than those in the IM aripiprazole group. So next I would like to discuss the adverse events that were reported throughout the study. All of these adverse events that were reported were considered a mild or moderate intensity, and no patients discontinued the study due to these adverse events. The most common adverse event reported was somnolence. This was reported at 14% in both groups, and somnolence is when a patient reports feeling drowsy or sleepy. The next most common adverse event reported was dysgeusia. This is the alteration of taste, and it was reported only in the inhaled loxapine group at 12.3%. And this makes sense that it was only reported in the inhaled loxapine group because the inhaled loxapine is an inhalation, and this is not an adverse event that would be likely to occur with an injection, so this is why we did not see it in the IM aripiprazole group. The next adverse event was reported in both groups, and this was dizziness at 2.2% in the inhaled loxapine group and 6.2% in the IM aripiprazole group. And the last two most commonly reported adverse events were cough and throat irritation, which were also only reported in the inhaled loxapine group. And again, that makes sense because that medication is an inhalation, and these are not adverse events that we would expect to see with an injection. I would also like to note that there were 2 patients in the trial who had asthma and did receive inhaled loxapine. However, there were no bronchospasm events reported within these patients. The strengths of this study are that it was in a real-world setting and conducted at 23 different centers across Europe, so there was a wide variety of patients included, and this patient population accurately reflected those that are more likely to seek treatment for agitation in a real-world setting. This was also the first head-to-head trial that compared inhaled loxapine to an established therapy for acute agitation. So in the 2 background trials that I discussed, inhaled loxapine was compared to placebo. So this trial compared it to IM aripiprazole. And inhaled loxapine did still show significance for a shorter time to response against IM aripiprazole. There are quite a few limitations to the study, however, the first being the open-label study design. So it would have been quite difficult to blind the difference between an inhalation and an injection in this patient population. However, because the patients and the providers were able to see what therapy was being given, this could have opened the floor to bias between the 2 therapies. It's also important to note that power was not met. The study investigators found that they would need 180 patients in each group for 90% power. They had 179 patients in the inhaled loxapine group and 178 patients in the IM aripiprazole group, so they were just short of meeting power. Furthermore, patients were allowed to take other medications during the course of the study, but it was not identified at any point what these medications were. It's probably unlikely that these medications were antipsychotics, but since they were not identified, we don't know what these medications were and if they had any impact on the outcome of treatment. Another limitation of the study is that the investigators did not strictly stick to their exclusion criteria, so patients with active airway disease or respiratory symptoms should have been excluded, yet there were still patients with asthma that were included in the trial and received inhaled loxapine. Though there were no bronchospasm events reported, these patients should have been excluded. Ultimately, the authors concluded that inhaled loxapine is superior to IM aripiprazole in decreasing the time to response via the CGI-I score during the first hour after drug administration in acutely agitated patients with schizophrenia or bipolar disorder. So having taken a look at these clinical trials, that brings us back to the guideline recommendations and the question that we were trying to answer about where inhaled loxapine fits into these recommendations. So using my clinical judgment and the data that I've discussed today, I would say it's appropriate to put inhaled loxapine as a third-line agent in these guideline recommendations. The first and second-line agents are oral, second, and first-generation antipsychotics, and oral is the typically preferred route of administration in most cases. However, in patients with acute agitation, the onset of action of oral agents may be just too long. Agitated patients can quickly progress to a worsened state, and those risks of harm or inpatient hospitalization may be too high to have an agent that doesn't have a quick onset of effect. So this is where inhaled loxapine comes in. Inhaled loxapine does have a quick onset of effect of about 2 minutes. It's non-invasive, whereas the parenteral second and first generation antipsychotics are invasive. Inhaled loxapine is not. It's also very easy to use. There is no hand-breath coordination or special technique required to use the inhaler. So even a patient who is in an agitated state and may not be able to learn a technique, they don't have to worry about that. They can still use the inhaler. It also respects the patient's autonomy. So patients who are agitated may not be in the best ability to choose their therapies, but healthcare providers are not able to force the patient to take an inhalation, whereas they are able to force the patient into restraints or to receive an injection that the patient may not want. So in this case, the patient is able to take autonomy for what treatment they want to receive. And ultimately, this in turn can help maintain that therapeutic alliance or the relationship between patient and healthcare provider by allowing that patient to have the autonomy for their therapy and not have therapies forced on them against their will. Overall, this could result in the best outcome for the patient therapy. Despite all of these benefits to inhaled loxapine, there are some limitations, the primary limitation being the REMS program. Facilities must be enrolled in the REMS program in order to be able to prescribe and administer inhaled loxapine. The REMS program that was not something that was discussed in the clinical trials or the PLACID study. Because the PLACID study took place in Europe, the REMS program is not something that occurs in Europe. That is something that is specific to the United States. So therefore, the REMS program was not an issue throughout that study. However, it would be an issue in the United States for facilities needing to be enrolled in the REMS program. Facilities may not have the resources or the ability to enroll in the REMS program, and even if they do, this medication does have that strict monitoring parameters that must be met, and there must be specific documentation of that monitoring as well. So it can be a lot more work. However, I think that the benefits of inhaled loxapine outweigh that limitation of the REMS program. I think that if facilities are able to have the resources available to enroll in the REMS program, inhaled loxapine is a great option that can be a quick and easy way to manage a patient's acute agitation without being invasive, and it also respects the patient's autonomy, allows them to be part of their treatment and have the best course of outcome. So with that, I would be happy to answer any questions that anyone may have about the use of inhaled loxapine for the treatment of acute agitation. Thank you.